Hello, my name's Lisa King, and I'm the core laboratory manager here at St. Joe's, Oakland. And I'm just going to cover a few things that pertain to the laboratory that might be helpful in your interaction with us. So the main lab is in the basement, and we have an outpatient lab, we have medical office labs, and we also have satellite labs. We have 4 pathologists, approximately 100 employees. That is made up of technologists and support staff. We do inpatient testing and outreach testing, and we do greater than 500,000 tests annually, and we're fully automated. So I mentioned before, we're in the basement, that we have a core lab and the blood bank, and then the anatomical pathology are near the Woodland G elevators. And then if you wanted to go to microbiology, they're near the medical records department. So when you come down to the basement to see us, you come to the entrance of our laboratory, and this is what it looks like. So in this area, we have chemistry, hematology, coagulation, blood bank, urinalysis, and then any send-outs that we send to other laboratories. This also is where you'd find blood bank, and we do have a window in the hallway where you can come and get your blood products. So anytime you send a sample to the laboratory, you'll have a laboratory label on it most of the time. And these labels have a lot of information on them. The patient name, first of all. Underneath that is a medical record number. Then you have a barcode label that is very critical to us in the laboratory, and we'll cover that in a second. A priority code, and this label is RT, meaning routine. A test code, that BC actually means blood culture. Financial number, they do have volume requirements on there. We do have the tube requirement there on the bottom. Any special instructions would be on there. We also at the top have the patient location, the patient room status, and the order date and time, patient age, date of birth, and a laboratory identification number, which is under that barcode. And then if it is a reprinted label, it also tells you that. On every specimen that comes down in the laboratory, we would need a date and time, and usually your initials. There are some exceptions to the initial rule, and we'll cover that in a second. So in blood bank, it's very particular. So I'm gonna it's always good to just get one routine and stay with it. So we're gonna try to get everyone to put their first initial and last name on the label, and then the date and time of collection. It's very important not to write on the barcode. The instruments all read the barcode, and if there's any writing near it, it won't read it, and then that delays turnaround time because the automated line will boot it off, and then it'll take someone to go retrieve that specimen, figure out why it booted it off, and then reprint a barcode and put it back on. Always write legibly, please. Next slide is labeling is important. So I went over a couple things about that barcode where you shouldn't write next to it, but you also try to put it on the label straight, the top of the tube, not near the bottom. And then a good reference would just be to put the label right over the existing tube label, the manufacturer label on the tube. And then one label per tube. If you butterfly the labels, meaning put more than one label on a tube, that just requires us to do it all by hand, which again can delay the turnaround time to get the result. So here's some examples of good and bad labeling. The green is a good one. Even though it's a little bit crooked, it's still okay. The instruments are going to be able to read that. They're not super picky about that, but they, to a degree. And it's labeled correctly. It has the date and the time on it. And then you can see it says C Yankee. The next one is not good because they use gel pens, and the gel pens obviously smear. And so that's going to, we can't read any of the information that you wrote on there. And we probably end up calling the floor to try to get some of the information. And so we will probably have a delay in the turnaround time again. The last one is what I was talking about earlier. The writing is too close to the barcode on the right there. And so the instrument is going to reject that specimen. And so then we'll have to just do it by hand. And there's just delays. Here are some examples of labeling microtainers. That's when you do a finger stick or a heel stick on a baby. So you always want to put the little tiny microtube in the adapter, which is that longer plastic tube. That's the green box at the top. So again, you're going to want to label that near the top. We don't want them coming down like the second and third one, just on the microtube, because we'll end up having to put it in a container, and it's just, again, delays, that's all. And then a placement of the label, if you could put it near the top. To the right, it shows our automated line. They call these pucks, and that's what the specimens go in, and then it goes down a line, and the automated line will read that barcode. But you can see someone put the barcode label too low, so most of the barcode is in the puck. So obviously the automated line wouldn't be able to read that, and they would shoot that off in the to be examined area. This is just another slide to kind of show how a volume of the blood in the tubes. If it's too low, then that also causes a delay because the automated line will read that as not enough specimen. So a good rule of thumb is to always fill up to the manufacturer's label. Now, when you do that, that doesn't mean it's going to be enough for testing. It just means that the automated line will read it as their specimen there. But you should always get as much in each tube as possible, and this just avoids delay, because if there's not enough for all the testing, we'll be able to report out a few things, but then we'll have to call you and ask you to redraw to get the rest of your testing that you wanted. So our laboratory is certified by the Joint Commission and CAP, which is the College of American Pathologists. So that being said, every specimen requires 2 identifiers, the name and the date of birth. Whenever you're collecting a specimen, you should label that specimen at the bedside before you leave the room. And you should be checking your laboratory label with the label, the hospital wristband. If there is a mislabel or an unlabeled specimen that comes down to us, it is immediately rejected, which means recollection. And relabeling is not allowed. We cannot have you come down and relabel it. And a lot of times we catch mislabels by Delta checks. So we have automated rules in place that search that patient specimen, let's say for a hemoglobin. If I get a 10, but the computers will look through and say, oh, we did that patient 3 hours ago and it was 14. So that's called a Delta check. And that would be flag us, because we have certain parameters set in place. And that's when you get calls from us and say, hey, were you expecting this person to have a low hemoglobin? Has he been bleeding, etc.? And if you say no, then that's when we say, well, we're going to need a redraw because we suspect that this is a mislabeled patient specimen. So blood bank is very critical and totally non-negotiable when it comes to labeling specimens. So what you have here in this video or this slide is a blood bank armband. And so when the armband is put on the patient, we have compared the patient's hospital armband and transcribed the information onto this armband. And then this armband goes on to the patient. The little barcode labels with every specimen that you draw for blood bank, one of those would be going on that pink tube. So here's a blood bank specimen. This one was done correctly. So you see you have the blood bank band barcode at the top from the blue band, and then you have the hospital label and the actually laboratory label underneath it. The blood bank band barcode is always an X, Y, or Z number. So then on this blood bank band specimen, you need to have the first initial and the last name clearly written on the tube with the date and the time of the draw. If this is not absolutely perfect, it will be rejected by the blood bank and sent back for recollection. So approximately 70% of all physicians' decisions are based on laboratory results. And so that is why it's so important for us to be extremely picky and make sure that we are sending out high quality results. And a lot of this is not just the laboratory, it's the collection, the transport, all those things are involved in these decisions. So that is why the laboratory ends up being very picky, it seems like. And it's because we know that the physicians look at these results and make decisions on them. So things that impact the results and the quality of your specimen. So we talked a little bit about fill level. Vacuum container tubes have a fill level. So they have a vacuum in there and it will stop when it's full. Okay. Proper ratio of the blood to anticoagulant is really important. So if you don't draw up to, like I was saying, that paper line, then for sure the ratio of anticoagulant that's in the tube to blood is wrong. And that can cause erroneous and improper results. So it's very important to always fill the vac container tubes as much as possible. And a very picky vac container tube is the blue top tube. This is what is all of your clotting tests are performed on. So these have to be filled up to the line, which is in the tube, it's like 90% full. And we will reject specimens that are not filled to that line that's on the tube. And this is just because we for sure have erroneous results with improperly filled tubes on the blue tops. Another thing that affects the quality of the result is hemolysis. Hemolysis can happen for several reasons. A traumatic draw. Drawing from an IV site gives us more hemolysis than from a regular vacuum phlebotomy draw. If you use a syringe, if you pull on that syringe too hard, then that will break the cells as they enter. If when you take that syringe and you fill a tube with it and you push down too hard, that'll break cells. So we highly encourage not to use a syringe, and we have adapters that will fit to your IV sites, and that will use the vacuum container holder. And then it's just using the vacuum of the tube then to fill the tubes. And that has all been studied, and manufacturers have done all sorts of things to make sure that the vacuum in that tube will not cause hemolysis. So hemolysis impacts potassium, liver enzymes, And there's several other tests that it impacts. And it's because a lot of our tests are, there's a couple of reasons, color related. So the reaction in the tube, the chemistries, is based on a color change. So if you have red plasma or serum, it's going to affect that color change. Another thing is that when the cells are broken, the contents of the cell spills out into the plasma, and that content contains like potassium. So that's going to raise your potassium level falsely. And we don't want a doctor treating someone for high potassium when it really isn't. It's just the hemolysis. And the hemolysis is flagged by our instruments. The technologists themselves do not observe that any longer. The instruments know exactly how much hemolysis will affect the testing, and it will flag it, and then we know that we can't report that result out. Another thing that affects the quality of the specimen are clots in the tubes. And this is caused by improper mixing, especially if you have a really difficult draw. We encourage you, if the blood is flowing in very slowly, to take the tube out, rock it, put it back in, let some more blood flow in there really slow, take it out, rock it, put it back in. That ensures that the anticoagulant is mixing with it before it starts to clot in the tube. And then expired tubes can affect results. So we went over some of these. Hemolysis pulling back on the syringe. Better to use a Vacutainer adapter. If you have a small beveled needle, if you shake the tube too hard, I don't know how hard you would have to shake it. It would have to be really, really hard to break the cells, but I guess it can happen. And then sometimes if you don't let the alcohol on the site dry and alcohol gets in there, that can break up the cells also. So if possible, never draw, well, for sure, never draw from an IV above it. That will contaminate the blood specimen for sure. And we do see that quite often. And we can tell just from the results if it has been drawn above an IV because the IV fluid has mixed in there. Never draw if edema or his arm is bruised. This is sometimes very difficult to do in a hospital setting. And then never draw on the side of a mastectomy due to the lymphatic system being compromised. This is just a chart of the of what is in each tube and what they're used for. So your blue top is for the coagulation, like I mentioned. You have a dark blue top or for trace elements. You have a red top, that's serum, and that's used for chemistries and several viral markers and immunochemistry, etc. You have a serum separator tube, which is also serum. No anticoagulant in there, but it may have a clot activator in there. You've got the orange tube that has a clot activator in it, and we use that for our troponins. You have a sodium heparin tube that we don't really use here. And then you have your green lithium heparin tubes, which we do use here. You have your lavender tops, which are EDTA, and that is for hematology, your CBCs. And then you have a pink top that also has EDTA in it, and that is what we use in blood bank. Then you have your very dark blue that looks very similar to the one up above, but it has EDTA in it also, and that is for heavy metals. And then you have a gray top tube, which is for potassium. It has potassium oxalate in it. And this is usually used as an outpatient, for outpatient draws for glucoses. So here's your order of draw. You always draw your blood cultures first, starting with the aerobic bottle and then the anaerobic bottle. Then comes your blue top tubes for coagulation, red top tubes, serum separator, orange top, then your greens, then your pink EDTA tubes, then gray or any dark blue plain. So it gets a little confusing sometimes when we say plasma and serum. So plasma that contains clotting factors. So these tubes don't clot. So it prevents the cells from clotting, and the plasma contains all of your clotting factors. So your blue top tubes are plasma, because we are definitely testing your clotting tubes. Your hematology tubes, which are purple, they're plasma, because we don't want the platelets all bunching up and clotting. We want to see what does that blood look like in the body. Serum clot. So if you were testing serum tubes, you would not be testing it for anything, any clotting factors or anything like that. So another thing to never ever do is never pour one tube to the next. You might think, oh, you know, I forgot to draw that lavender top. I'm going to take the screen top and I'm going to pour some blood in there. No, no, no. Lavender tops contain the anticoagulant EDTA. Green tops contain lithium heparin. And if we're doing chemistries and you've poured some lavender into a green, we're going to see that right away, because a lot of the chemistry results will come out really not conducive to life. So a lot of times we call and say, hey, it's kind of funny. Sometimes the nurses will be like, how did you know that? They think we're psychic, but we're not. It's just the blood results come out really goofy looking, and we see it right away. So please never, ever pour one top to another. Each color is specific to an anticoagulant and specific to a department in the laboratory. And then your orange troponin tube is a fairly new tube, and it's serum, but it does have a clotting activator in it, because we want to get those troponins out to you as soon as possible. So we need that tube to clot really fast so we can test that serum. Always mix your tubes when you're drawing at least 10 times, gently back and forth, and that mixes the anticoagulant with the blood. So if a doctor has ordered a CBC, PT, and electrolytes, what tubes do you need? And then what order should you draw them in? So you're going to need a blue, a green, and a lavender, and you're going to draw them in that order: blue, green, lavender. So microtainer tubes or finger stick tubes are very fussy tubes. They're supposed to be filled to a designated line on the tube. You must put that top on really tight. And then you must put it on a microadapter. That's that plastic little tube at the bottom of the screen. And that's where you label the tube. My finger sticks can be used for chemistry and CBCs. You cannot use one for coag tests. The trick to getting a good finger stick is to tap the blood, like squeeze the finger, put some blood in there, tap, 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 tap. And that gets the blood down into the anticoagulant. One of the main things that happens with microtainers tubes is that they clot, and then we have to reject them. So the sooner you can get that blood in contact with that anticoagulant, the better it will be. So we have stats here, and those are reserved for critical patients. We have routine or normal. Those are drawn in like sweeps. So the phlebotomists will come up with a bunch and they'll do a sweep. And then maybe a few hours later, they come through and they do another sweep. And then you have TS, which are usually drug levels or coagulation studies that are timed draws. So the nursing are well aware of the EPIC system. That's what the hospital uses. The EPIC system is separate from what the lab uses. We do use EPIC, but we also use a lab system specifically for our purposes. Specimens that are marked lab collect or unit collect. And phlebotomists, they'll collect all the ones that say lab collect, but the RN staff will collect anything that says unit collect. Labels for lab collect specimens will automatically print to the designated printers, and they will need to be collected and put into the unit designated lab book, which is on each corner. Labs that labeled unit collect will appear on the brain and work list tab. These include the following, like non-blood specimens, blood specimens that are collected that are labeled unit collect, or point of care tests. So nurse and unit collect specimens, you would go to a work list in Epic and any specimen that is not a blood draw to obtain a label. And then examples of those would be urine or sputum. So other specimens that the lab performs tests on, as I just said, urines, which can be random ones or 24-hour collections. There's pathology specimens, tissues, and then there's microbiology specimens. All specimens must be sealed in a specific specimen bag, and then they are sent to station 120. Very, very important to check all your lids on your specimens to prevent leaks. Because if something leaks and it comes out of the bag, the entire system gets shut down for cleaning, and that's very disruptive. You want to pad specimens like for blood cultures because they're glass, the anaerobic bottle is. And so there's special padded pneumatic tubes that you would send those down in, or you just would wrap it up really good with a towel or something just to pad it so it's not going to break in transport. So you just want to follow the St. Joe's Medical Oakland policy. And then do not overload or stuff the carriers, because if you can't shut them really well, then they'll explode and again shut down the tube system. So prompt delivery to the lab is very essential. Don't want to let specimens sit because some of the blood tests need to be spun in a certain amount of time from point of draw. Other specimens like urine, things like that, bacteria starts to grow in them before they get to us. So you want to just, any lab specimen, you just want to get it tubed down to us as soon as possible. And if the tube is down, the pneumatic tube, then you just hand deliver it to the lab, and we'll direct you where to drop it off, but that's a little picture of where you would drop it off in the laboratory. So during downtime, there is a requisition that can be used. It's in the back of the phlebotomy books, or you just would ask your manager. You'd want to place a PLUI label or a hospital label on each page of the form. If you don't, and the top page gets separated, which they do sometimes, then we have no idea whose order that was in the laboratory. So you want to make sure and have patient name, date of birth, PLUI label on every single page of that form. And then if you can make sure the room number's on each page too, so we know where to call any criticals or questions that we have. The downtime section of the phlebotomy book has collection requirements in it also. So you can find the lab collection manual on the internet and intranet, and you can also call the laboratory because we always have staff there 24/7. We never close. Thank you very much for your attention today, and if you ever have any questions, please always feel free to call the laboratory. Thank you.